Hey guys, I just first of all wanted to apologize to you all. This has probably been the worst teaching that I've done, but I've been very busy and I know that you guys have needed to have this. And the last videos, I woke up at like 9 at night because I had fallen asleep, and I quickly got up and started doing the teaching. So I really apologize because I feel like it was so disconnected and not my best work at all. Again, I apologize. And then I just want to say I just got off of work today, so again, it's probably not going to be my best work, but I'm going to try very hard to give you guys what you need. So that being said, I just want to start right now with talking about chapter 35, which is nursing care of the patient with liver, pancreatic, and gallbladder disorders. So first thing we're going to talk about is hepatitis. Hepatitis just is inflammation of the liver. If you don't fix hepatitis, it moves to cirrhosis, which will move to liver failure. So there is a progression of that, and you can have cirrhosis without having hepatitis, but because hepatitis just simply means inflammation of the liver, that's usually typically what you're going to have first. Inflammation of the liver, and the inflammation can be caused by different things. It can be caused by bacterial infection, viral infection, can be caused by certain medications like Tylenol overdose, aspirin overdose. It can also be caused by metabolic disorders like a buildup of iron or copper, and it can also be caused by toxins like alcohol. So that being said, you know that you have hepatitis A, B, C, D, E, and G. When I told that to Mike, he was like, "Are you serious? You know, you hear about hepatitis A, you hear about hepatitis B, hep C, but typically you don't hear about D, E, and G." So, and from that, you need to know that hepatitis A and hepatitis B are the only two types of hepatitis that have vaccines available for them. And the rest, hepatitis C, once you get it, you get it. And that's just the way it goes. There's no cure for it as of yet. And now they do have antivirals, but antivirals actually deal with the symptoms. They don't cure the disease. So that is what hepatitis is, but let's talk about what it looks like. What are some of the signs and symptoms? How are we going to be able to see that our patient has hepatitis? Well, there's 3 phases of hepatitis that you should know about. One is called the prodromal phase, and if you have your books, I'm on page 780 in my book, and it's talking about prodromal phase is when the patient doesn't really know that they have the disease. It's about 2 weeks after exposure, and they're going to feel like they have the flu. They're going to have malaise. They're going to feel flu-like symptoms, maybe some headache, maybe some right upper quadrant tenderness. But all in all, they're just going to think that they have the flu. And then the icteric phase comes in. And when that comes in, that's when jaundice happens. And the jaundice can be in their skin, or the urine can start to have a bright orange color to it because of the buildup of bilirubin. So then the urine can be bright orange, and that's where you can see it in that. And that jaundice phase, or the icteric phase, usually lasts anywhere from 5 to 10 days after the prodromal to about 2 to 6 weeks. So the icteric phase of hepatitis, it's a long phase, 2 to 6 weeks. And then you have the convalescent phase where the jaundice starts to go away and the patient actually starts to feel better. But if you don't fix hepatitis, then it can cause what the book calls fulminant liver failure. Fulminant just is a fancy word that means complete, sudden and severe. So when you say somebody has fulminant liver failure, you're just saying that the liver failure was sudden and severe. Okay? So don't get caught up in that. But how is the doctor going to know that our patient has liver failure? Well, there's going to be certain tests that they take. There's going to be ASTs, ALTs, and alkaline phosphate. Those are your three primary livers: ALTs, ASTs, and alkaline phosphate. And all three of those liver tests are going to be elevated. Okay, so what do we do? What do we do for our patients? So we already know now they have elevated liver functions. They're going to do a CT of the liver. They're going to find out, okay, this person has liver or hepatitis. So what do we do as nurses? Well, basically what the doctor's going to do is the doctor is going to monitor their liver status by monitoring their ALTs, ASTs, and alkaline phosphate. And then they're also going to basically just provide symptomatic relief. So if they're in pain, they're going to give them pain medicine. If they're itching, they're going to give them some antipruritic medication. But what we do is we are going to monitor their pain level, and we're going to give the analgesics as the doctor prescribes. We're going to monitor their weight gain and their nutritional intake to determine their nutritional needs, because these people aren't going to feel like eating. They're going to be anorexic, not have anorexia nervosa, but they're going to be anorexic because they're not going to feel like they're eating. And it's important that we provide for this patient a high calorie, high protein, high complex carbohydrate diet. Okay? These people are also, because they're going to feel like they're having the flu, they're also going to need antiemetics. So some of your antiemetics that you're going to give them would be Phenergan, Compazine, Zofran. Those are your antiemetics that you would expect to give. All right? We're going to make sure that the patient is placed in an upright and sitting position. And we're going to do everything that we can to support nutrition. Then we're also going to do alcohol awareness treatment, because people with hepatitis, because their liver is inflamed, at this point, alcohol is extremely toxic to the already inflamed liver. So, alcohol awareness and alcohol teaching is extremely important, as well as vitamin supplements, because right now the liver isn't working like it needs to, so the synthesis that normally happens in the liver is not happening in our patient. Okay? And then let's remember that this person is going to have itchiness because of the bilirubin that's up underneath their skin. So we need to do very good skin care on this patient, because they're going to be itching. Anytime they itch, they're going to scratch. Scratching leads to open skin wounds, and then we've got a whole nother set of problems that we're going to. And then, of course, as nurses, we always want to educate our patients. So we're letting them know what caused the hepatitis, how to avoid the hepatitis. If they need to be vaccinated, we're going to teach them about vaccination, all of those types of things. So, if you don't fix hepatitis, like I said, it can lead to fulminant liver disease or acute liver failure. Okay? So what is acute liver failure? Acute liver failure is, it usually develops in about 2 days, and it is just what it sounds like. It is a sudden failure of the liver. So if the liver is failing, then what's going to happen? Well, what happens in the liver? The drugs are metabolized in the liver. So if drugs are metabolized in the liver and the liver is failing, then these people are going to be at risk of having a toxic amount of medications in their system because the liver isn't metabolizing it. So more of the drug is staying in the blood. So we have to really watch that. The other thing that we have to watch for with this is that it's not breaking down, or it's breaking down too much, the proteins, and it's not synthesizing different vitamins that it's supposed to be synthesizing. So your cholesterol is going to be out of whack, your bilirubin's going to be out of whack, your platelet counts are going to be out of whack, your because this is all stuff that's happening in the liver. So if the liver is failing, all of these other areas are going to be affected. So I hope that you're following me as I'm talking about this. Well, the other thing that you need to know is that your ALTs, ASTs, and your alkaline phosphate is all going to be extremely elevated. Your prothrombin time is elevated, and your potassium and your blood glucose levels are going to drop. Okay? So at this point, medical treatment is going to be directed just at stopping or reversing the damage to the liver. All right? And our focus as nurses is going to be going back to the same types of focus that we had when they had hepatitis. It's that same type of focus that we're going to have. We want to make sure that our patient is comfortable, that we're administering medications in a timely manner, that we're administering antiemetics, we're encouraging nutrition, that we are administering I just lost my train of thought. That we are administering vitamin supplements on a routine basis, and that is acute liver failure. So you see that you have hepatitis, inflammation of the liver. If you don't fix that, it's going to go into acute liver failure. If you don't fix that, then the acute liver failure is going to turn into chronic liver failure or cirrhosis. Cirrhosis of the liver is the progressive, and I'm on page 785 in the book if you need to follow along. Cirrhosis is the progressive, irreversible replacement of healthy liver tissue with scar tissue. And the number one way that we are, or most people are familiar with cirrhosis, is cirrhosis of the liver due to alcohol abuse. All right? So, healthy liver cells become inflamed, and then those cells are infiltrated with fat and white blood cells, and they're replaced by fibrotic tissues. So those fibrotic tissues are not supple, they become stiff and banded, and the liver cells can't move, they can't breathe, they can't get exchange of oxygen. So that liver, the cirrhotic liver, becomes basically just a band of fibrous tissue that makes it hardened. All right, so what are some signs and symptoms of cirrhosis? Well, initially, you're going to have your liver functions are going to be impaired, and then you're going to start to see anorexia, nausea, vomiting, weight loss, and fatigue. And then you're going to start to see that the patient's skin is going to become dry and itchy. And then the liver is going to become enlarged, and your liver functions are going to be increasingly higher and higher and higher. And then there's going to be a loss of liver function altogether, and all the complications that arise from loss of liver function are going to start to occur. And those complications are complications in blood clotting, because remember, blood clotting, your vitamin K deficiency is going to start. So if you have vitamin K deficiency, then you're not going to clot like you need to. Portal hypertension is going to start to happen. Ascites, which is a collection of fluid in the abdomen. Hepatic encephalopathy. Hepatic encephalopathy is another thing that you need to know about, and that's caused by the breakdown, or it's caused by the buildup of ammonia that comes from the breakdown of proteins. And normally our liver is able to take those protein or that ammonia and dilute it and flush it out of our body, and it's never a problem. We don't even know about it. But when our liver fails, then our liver can't dilute that ammonia, and that ammonia goes to our brain, and that person can seem like they need to be Baker acted. They can seem like they're drunk. They can seem like they have a loss of LOC. Well, it's not like they're in a coma, but they're not. They are no longer oriented to person, place, or time. All right. They can get flapping tremors in their hands with hepatic encephalopathy, and those people usually have to have an order of lactulose. People with hepatic encephalopathy usually have lactulose that brings down the ammonia levels, and you'll see in your patient that as those ammonia levels are brought down, their orientation, their mentation, their mental status comes back into play again. All right? So again, how are they going to test for a hepatic encephalopathy? Well, they're going to do all of the normal ALTs, ASTs, alkaline phosphate, but then they're also going to start to add ammonia levels in there. And people with hepatic encephalopathy can have very high ammonia levels. And I'm telling you, this is classic. I just took care of a patient this weekend who had hepatic encephalopathy, and it looks just like what the book says it looks like. The flapping tremors of the hand called hysterexis. And then you have fetor hepaticus, which just means foul breath, because the byproducts of the breakdown, or the incorrect breakdown of different chemicals when the liver isn't working, makes it smell like sulfur, like rotten eggs. So their breath is going to smell like rotten eggs, and their mentation is just going to be all over the place. And then they're going to have the hysterexis, which is the flapping, twitching of the hands. All right? The patient is often going to be belligerent, irritable. They're going to seem like they need to be Baker acted, or that you could even call a code gray on them, because they just become loud and belligerent, because truly they are out of their mind right now. Their brain, which is where the encephalopathy comes from, their brain becomes invaded with the toxin of ammonia. Okay, so on Miss Stevenson's study guide, then I covered number 19 and number 20, where it talks about hepatitis types, signs and symptoms, treatments and medications. And number 20, hepatic encephalopathy, signs and symptoms, treatments and meds. And so now I'm going to cover, and I also covered liver failure, acute and chronic, signs and symptoms, treatments and meds. So now I'm going to cover liver transplant. So first of all, when you talk about liver transplant, the thing that you need to know is that these people are going to be on steroids, because the steroids are anti-inflammatories, and they're also going to be on anti-rejection drugs. So these people are going to be extremely susceptible to getting sick, because the anti-rejection drugs lower your body's immunity so that it doesn't reject the liver transplant. But when your body's immunity is lower, then what ends up happening? you end up being more susceptible to other diseases. Okay, so liver transplantation information is on page 791. You have to find the correct donor match, so their tissue markers have to be the same, and then their blood type has to be the same. And let's see, the patient will be on drugs such as cyclosporin, Protopic, Imuron, prednisone, and Cellcept. And all of those things suppress the immune system, all right? But here are signs and symptoms of rejection, and this is something you need to know. I'm on page 791, and the signs and symptoms of transplant rejection are pulse that's greater than 100 beats per minute, temperature greater than 101 degrees, right upper quadrant pain, increased jaundice, or decrease in bile from the T-tube, or changes in bile color. Now, a T-tube is just a tube, literally, that looks like a T, but it's going to collect drainage. But the drainage goes through the T-tube, and that's all that it is. It's just a tube that, it's a drainage tube that looks like a T. That's the best way to explain it to you. Okay, so that takes us through 19, 20, 21, and 22. So the next thing that I want to talk to you about is esophageal varices. Esophageal varices is actually bleeding in the esophagus, but it's bleeding in the esophagus that's due to liver damage. Esophageal varices are most commonly associated with alcohol abuse. But what is going to happen is that patient is going to start to vomit blood, and the blood is coming from the blood is coming from varices or corroded veins in the esophagus. And that's really what esophageal varices are. They're like corroded veins in the esophagus. All right? So the medical goal to esophageal varices is to stop the bleeding. All right? Maintain normal clotting and treat infection. So how do we stop those esophageal varices? Well, the first thing that we're going to do is we're going to give octreotide, and that's sandostatin. That's given IV, and that's going to cause those varices to constrict, and that's what we want. We want the constriction, because as they constrict, they're going to put pressure, and that's going to stop the bleeding in the esophagus. All right? So that drug is called sandostatin or octreotide. And oftentimes in the acute care setting, you're going to see an octreotide drip. And that drip is used to cause vasoconstriction. All right? The other thing that we might see is that vitamin K is going to oftentimes be given as a supplement, because vitamin K promotes clotting. That's why our babies, when they're born, they're given a shot of vitamin K, because their liver is not fully formed yet, so they don't have enough vitamin K. So we give them a shot of vitamin K, and that helps the clotting factor. So when our liver isn't working, then we need to give our patients vitamin K supplements, and that's going to help to promote the clotting factors. All right. The other thing that they might do is they might actually do an endoscopy where they do a banding of those varices, and literally they go in and it looks like a rubber band, but it's not really, but it's like a rubber band, and it's really like a belt, and they'll actually go in around the varices, the corroded varices, and they'll tighten the belts up to put pressure around those areas that are bleeding. And when everything else fails, they'll actually go in there and they might put an esophageal tamponade, where they go in there with a tube and they'll blow up the tube like a Foley catheter type of tube. It's not a Foley catheter, but it's like that, a tube that has a balloon in there, and they'll put the balloon, the sterile water in the balloon, and that will be in that person's esophagus, and the pressure from the balloon will put pressure up against those esophageal varices, and it'll stop the bleeding. That's very uncomfortable for the patient, and so that is a last-ditch effort. But that's what esophageal varices are. Okay, so number 24 on the list is acute and chronic pancreatitis. Signs and symptoms, treatments, and medications. Well, that is on page 792 in our book. Acute pancreatitis means it's sudden, and it's a sudden inflammation of the pancreas. All right. When there is inflammation of the pancreas, your amylase and your lipase levels are going to be severely elevated. And that patient is going to have mid-epigastric pain. They're going to have nausea, vomiting. They're going to guard their abdomen, or their abdomen is going to become very rigid. Okay? And they could even have like a fullness up in their chest because of the accumulation of fluid in the retroperitoneal space. So that's the area right underneath our diaphragm. And if that area gets filled with fluid, then that fluid is going to put pressure up on the diaphragm, which is going to cause respiratory distress in our patients. Okay? So, when you think about acute pancreatitis, you need to expect that our patient is going to go for X-ray examinations. They're going to go for a CT they usually do an abdominal CT, which will show the liver, the pancreas, the gallbladder, and they're going to look at that whole area there to see what's going on. One of the common reasons that somebody has acute pancreatitis that is young, if you have a person in their 30s to 50s and they have pancreatitis, it's usually caused by alcohol. It's usually alcohol related, alcohol abuse. All right, so what are they going to do for this patient after they do their amylase and lipase levels and find that they're elevated? They're going to do X-ray exams, find that pancreas is inflamed. So then we should suspect that our patient is going to be on an NPO diet, nothing by mouth. They're going to give that pancreas a rest, okay? And they could be on NPO status for a prolonged amount of time, and if that's the case, then we should start to suspect that our patient just may end up on TPN, total parenteral nutrition. Pain medicine, we're going to want to do Dilaudid for this patient because that's probably one of the most potent and effective pain medications for pancreatitis. All right? A lot of times they're given anti-anxiety agents like Xanax or lorazepam to try and bring down their anxiety, bring down it helps to work with the pain medicine to help bring some relief, because remember, these people are going to be short of breath because of the fluid accumulation in that area underneath the diaphragm. So they're going to be short of breath, they're going to be in pain, they're not going to feel like eating or drinking anything, and they're not going to feel like getting up and walking around and running marathons. All right? Then the aim is, once that pancreas has been NPO or had a chance to rest, and you start to give antibiotics and the inflammation is relieved, that's the end of acute pancreatitis. However, is if it recurs, if you have several episodes of acute pancreatitis, it's no longer acute and it becomes chronic pancreatitis. Okay? Chronic pancreatitis is where there's actually been cellular damage in the pancreas because of the acute episodes that have happened. Okay? Now remember that the pancreas, it does affect diabetes, and we know about that, but it also secretes digestive enzymes. So if there's chronic pancreatitis, you're not only going to have problems with your blood sugar being regulated, but you're going to also miss digestive enzymes, and those people are often going to have to take supplemental digestive enzymes to help balance it out. The major cause of chronic pancreatitis in men is excessive alcohol ingestion. All right? The major cause in women is chronic obstructive biliary disease. Okay? And so gallstones in women can lead to chronic pancreatitis, and excessive alcohol abuse in men are going to lead to chronic pancreatitis. All right, signs and symptoms. They're going to generally be less severe than acute, but they're going to be the same. They're going to be the same symptoms, just less severe and over a longer period of time. All right? And the patient's going to have epigastric or lower upper quadrant pain, weight loss, and anorexia. Diagnostic tests are going to include elevated serum amylase and serum lipase levels, and that's going to be typically in the acute phase, but if it's chronic, those may not even be, they're going to be normal, or they may go the opposite direction, below normal. Okay? CT is going to show characteristic pancreatic structural changes. So that means that over time, with chronic pancreatitis, the actual shape or the actual structure of the pancreas is going to change. And that is number 24. I've got 25 through 28, and then I'm done. And actually 28 I went over when I talked about fulminant liver failure. I talked about that. So now I'm going to talk about gallstones, cholelithiasis, and cholecystectomy. And when I talk about cholecystectomy, that is a gallbladder removal. If I talk about cholelithiasis, that's talking about gallstones. And so I'm not quite sure why she has gallstones and then cholelithiasis, because they're the same thing. So without further ado, let's get to it. I'm going to look in the book real quick and find out what page it's on. Alrighty. I'm on page 802 in the book. So, cholecystitis, that's inflammation, whether it's acute or chronic inflammation of the gallbladder. That is going to, the inflammation most often is caused by cholelithiasis, which are gallstones. So what happens is the gallstones are made up of usually cholesterol, and those gallstones get stuck in the biliary duct, or they get stuck in the gallbladder itself, and the gallbladder becomes inflamed. When that gallbladder becomes inflamed, it has severe, excruciating pain that's usually referred to the to the shoulder blades, right in between the shoulder blades. And it's usually caused after a fatty meal. So somebody can go and eat a fat, juicy greasy hamburger, and then that night come in and have a sudden acute acute attack of cholecystitis, inflammation of the gallbladder. Okay? So, cholelithiasis is pooling or stasis of bile within the gallbladder, usually because of stones. And that's the stasis of the bile is actually what starts to form the stones. And as the stones get formed, then the inflammation happens and a backup of the bile happens. And so this person is in severe biliary colic. And it usually lasts 4 to 6 hours for an episode. And these people are usually writhing in pain because they can't find a comfortable position to lay in. So they're constantly moving around trying to find that one comfortable spot, and there just is none. So, of course, because it's an inflammation, it's usually an infection of some kind, you're going to suspect that that person is going to be put on some antibiotics. Kept in PO, they usually have a HIDA scan and a CT scan done. HIDA scan is a nuclear scan, and then the CT of the abdomen is done. That's going to show inflamed gallbladder. Okay? If that happens, then there's two things that can happen. They can go in and they can have surgery that removes the gallbladder and part of the biliary tract, or they can go in and have an ESWL, extracorporeal shockwave lithotripsy. Extracorporeal just means outside of the body, shockwave lithotripsy, and that is literally where they use ultrasonic waves across the abdomen to go in, and it's like a pounding of the abdomen, a constant pounding of the abdomen, and if that pounding of the abdomen will break up those stones in the gallbladder so that they can be more easily passed. And some of the effects of that, though, is that people can actually feel bruised and beaten because it literally is a beating of their abdomen with ultrasonic waves. They can also actually have like little chemical burns or skin breakdown from the constant beating of the ESWL. Okay? If they go in for cholecystectomy, you need to make sure that they are kept in PO, usually 8 to 12 hours beforehand. You need to make sure that they, let's see, MPO, sorry, I just lost my train of thought. I'm watching Mike eat dinner while I'm talking over here, and I just lost my train of thought because I suddenly realized I'm very hungry. Alright, so you need to keep them in PO. You need to make sure that the consent is signed. Sorry, that's where my train of thought was going. Make sure that the consent is signed, they've been kept in PO, and suspect that they're going to try and do it laparoscopically at first, and there's going to be 3 or 4 incisions, usually like 1, 2, 3 across the abdomen, and then 1 below the umbilical, below the belly button. And if that happens, then that means that that person is going to recover more quickly. They'll probably be out, maybe not the next day, but usually the next day or 2 days post-op, they'll be out. As opposed to having a complete or open cholecystectomy where they actually have to go in and do a complete abdominal incision, go in and remove that gallbladder. And that usually happens if the gallstones are too big to be broken up or cut out and pulled out with the laparoscopic tool. Okay, that, my friends, honestly, is the end of chapter 35. That was very quick, but it really did go over that.
Some Part B stuff.
Part B stuff?
Yeah, just that.
Okay, So Mike just handed me this Part B stuff that I am not even familiar with at all, so I'm going to have to try and fake it till I make it. Give me just a second to look and see. Oh, okay. It's chapter 19 in your NCLEX book, and it's really where it's talking about the different types of tubes. And I did go over some of that with you, because remember, the Levin tube is single lumen, and it's for gastric decompression. And you can't use continual suction on that. But then you have the Salem sump tube that is used for continuous suction, and it's double lumen because there's two S's, Salem sump. So really just, oh my gosh, I can't believe he did this to me.
Those are the things that go with it. The things that you are with.
Okay, I'm gonna stop this and give another video. I'm just gonna stop this and give another video after I look at this chapter, because I can't read it and synthesize it in the amount of time to make it meaningful to you guys. So, adios.